So we're going to start our next session, which is very exciting for this meeting because this is an abstract-driven session, which is going to be moderated by Dr. Ruben Granich when he's done schmoozing. Dr. Granich.
So welcome everybody to the oral abstract session. Those of you out there having coffee, you're missing it. This is going to be great. This is last session there was some complaints about the lack of science. This session is going to be filled with science, and we've got some really great presentations. What I'm going to do is I'm actually going to introduce everybody, and then they can go up one by one and make a short presentation, and then we'll take questions for everybody at the end. And if you could just direct your questions, does that sound okay for the panelists? Great. So we have Beth Rackless, and she's from the academic model providing access to healthcare, and that's AMPATH in Kenya. She's got a great talk on gaps in care among adults receiving HIV care in Western Kenya. We have Becky Genberg presenting from Brown University, and you're also from AMPATH as well, or is it? Brown and AMPATH. Okay, I've got a little cheat sheet here. And she's going to talk about population-based public health approach, population versus facility-level metrics for measuring engagement within the HIV care cascade. And then we have Sunil Solomon, who's going to be presenting monitoring effectiveness. Oh, he's actually from Johns Hopkins. Sorry, didn't mean to diss that great university. Monitoring effectiveness of HIV programs in the era of implementation science, utilizing a sample of 27,000 drug users and men who have sex with men in India. Going to be a great talk. And then we have Arthur Poon, who's coming from the BC Center for Excellence in Vancouver, and he's going to be talking about implementation of near real-time phylogenetic monitoring program for HIV transmission breaks. And my instructions to them was that they were supposed to have fun, present their science, and hopefully we'll get some good feedback from the crowd. So if Beth Rackless could take it away, please.
Good afternoon. Thank you for having me. Before I begin my presentation, I just wanted to acknowledge two of my co-investigators who are actually in the room with me, Dr. Paula Breitstein in the back, she can wave her hand, and Dr. Becky Genberg. So I'm going to be talking to you today very briefly about gaps in HIV care in Western Kenya in a cohort of adult HIV patients. So we're all familiar with the need for continuous engagement in HIV care. This is important for achieving optimal clinical outcomes as well as for social outcomes such as acceptance of one's HIV status. Disruption of HIV care and more specifically the discontinuation of antiretroviral therapy can lead to very poor clinical outcomes, opportunistic infections, and death. So we know this is very important. There's been a fair amount of research on losses to follow-up. A 2010 systematic review by Sidney Rosen and Matthew Fox noted that in 39 African ART cohorts, by 2 years, about 25% of the populations were no longer in care. Now, while some of those patients had died and transferred out, the majority had in fact become lost to follow-up. Now, some patients might not actually become lost to follow-up. Instead, what they might be doing is experiencing transient gaps in care in the sense that they are missing scheduled visits by a certain period of time, but eventually returning to care. Now, this has been explored a little bit in high-income countries, but it is less understood in low- and middle-income countries where I'm currently working. So my objective is to describe gaps in care among adult HIV patients receiving HIV care in Western Kenya. So some of you may be familiar with the academic model providing access to healthcare. It was initiated in 2001 as a joint partnership between Moi Teaching and Referral Hospital, Moi University, and several American universities, North American universities, really led at the moment by Indiana University School of Medicine. PEPFAR funding began in 2004. Currently, about 85,000 individuals are being actively followed in various sites, and there's a map here of Western Kenya demonstrating the various sites, AMPATH-supported sites where care is being provided. TB and HIV care is provided free of charge, and patients are managed according to the Kenyan and WHO health guidelines. AMPATH also uses a computerized medical record system to monitor their patients, and this has been expanded globally as OpenMRS, and the AMPATH system is called AMPATH Medical Record System, or AMRS. So this analysis that I'm presenting includes adult patients who are 18 years of age or over, who are known to be HIV positive and had enrolled in AMPAS-supported sites between January 2008 and August 2013, and they must have had at least one follow-up visit as recorded in the AMRS system. Now, we came up with several different definitions of Gaap, coming up with the idea that not all gaps are essentially created equal. So as we've defined it, a short gap is a situation where a patient has missed a visit by about at least a week, but has returned within 3 months of their expected return date. A median gap is missing a scheduled visit by at least 3 months, but returning within 1 year. A long gap is missing a scheduled visit by at least 1 year, but returning before the database closure. And then for individuals who are at least a year late and who did not return and were not known to have died or transferred to another facility, these were the patients that we considered lost to follow-up. So essentially at the moment I'm just presenting a cross-sectional data set. So I'm just presenting overall summary statistics. And the results that I'm going to be presenting are stratified according to ART status. So for individuals who were pre-ART and hadn't yet initiated antiretroviral therapy, as well as those who had. So approximately 57,000 individuals are included in this analysis, with just under 1 million follow-up visits. The median number of follow-up visits was 15, but the range was actually 2 visits to 86 visits. The median age is 35, 66% of the population was female, and 73% had ever initiated antiretroviral therapy. So you can see here from this table, among all patients, approximately 33% had had at least one short gap over time. Just under 17% had had a median gap, and just under 5% had had a longer gap. So as the gaps get longer, there's fewer patients who experience those gaps. Across the entire cohort, 31% of the individuals had been defined as lost to follow-up. Now, if we look at the stratified analysis, we can see that the pre-ART patients, the proportion experiencing gaps is actually smaller, but the number who are completely lost to follow-up is much higher at about 63% compared to individuals who had initiated antiretroviral therapy. So what we can decide and determine here is that gaps are quite common in our setting. They seem to occur quite commonly among patients who had not yet initiated therapy versus those who had. And this suggests that we need to develop strategies that encourage continuous engagement in HIV care, and particularly, to keep those who have yet to initiate therapy in care before they become lost. Now, there's numerous limitations of this analysis. It's a cross-sectional data set, so we can't really establish causality. Various patients obviously had multiple visits, which we're not accounting for in this analysis. It's just presenting at the patient level. And the definitions of gaps that we came up with may not be generalizable or agreeable to other programs and settings. So the next step with this analysis is to look at this issue longitudinally. So looking at all the patients that we've included and looking at their visits over time to determine predictors of gaps and looking at outcomes of patients with gaps. Are those patients who experience gaps more likely to become lost at a later time, or are they more likely to die? So related to this is linking the gaps with clinical outcomes such as changes in viral load and CD4 count. The final thing that we're going to be looking at is an evaluation of AMPAS outreach programs. So this is when patients miss visits, individuals are sent after them to try to track them down, figure out where they are, and encourage their return to care. So what we would like to do is be able to determine if individuals who miss visits and are traced, are these individuals more likely to return to care, so therefore are they less likely to become lost, or are they more likely to experience shorter gaps when they experience gaps? So this will be the upcoming analysis that we are working on. And finally, I just wanted to acknowledge funding and my team partners. Thank you very much.
That was super. That's great. Thank you. So we'll have Becky Genberg now.
Thanks very much. I would like to acknowledge my co-authors on this paper, Edwin Sang and Monica Nyambora from the AMPAS program, Beth Rackless, who you just heard from, Kara Walsh-Kalustian and Paula Breitstein from IU, and Joe Hogan from Brown University. So the implementation of TASP, as we've all been talking about this morning, requires the universal identification of people living with HIV, engaging those diagnosed in HIV care, and retaining them in care over time. A population approach would extend to all people living with HIV in communities, not just those who seek care through the healthcare system. Most existing research, however, on engagement in the HIV care continuum has been limited to facility-based estimates, or estimates of longitudinal losses that occur among those who enroll in care. Home-based counseling and testing, as we've heard earlier this morning, has been shown to identify those with HIV earlier in the course of their disease progression than other testing strategies, but the patterns of engagement in care among these healthier individuals necessary to the successful implementation of TASP remains largely unknown in resource-limited settings. So the objective of this analysis was to take advantage of population-based data from home-based counseling and testing in Western Kenya to examine engagement and retention in the HIV care continuum, comparing facility and population-level estimates. Beth just introduced you to the AMPATH program, so I can go a little quicker through this. AMPATH has been providing home-based counseling and testing in 22 sub-countings in Western Kenya since 2007. And the data in this analysis is taken from one high-prevalence sub-county, Bunyala, which is indicated on the map here by a large red arrow. And the home-based counseling and testing occurred there from December 2009 through January 2011. Data from HBCT was merged with AMRS data, which is AMPATH medical records data, to determine outcomes on the HIV care continuum following HBCT. This analysis included all those who were identified as HIV positive during HBCT. And the outcomes that we were interested in were they enrolled in care, CD4 testing, initiation of ART, retention on ART, and retention in care over time. And we used descriptive statistics to compare facility versus population-based metrics. So HBCT identified 3,788 individuals with HIV living in Bunyala sub-counting. Among those, 61% were previously diagnosed. As of June 2014, 2,247, which is 59%, had engaged in care. If we look at the data from the facility-based perspective, you can see that among all those who engaged in care, 92% had a CD4 count and 89% initiated ART. Among those who initiated ART, 93% were retained and 86% were retained in care overall. Contrast that with the population perspective, which shows that 59% of those who were identified during HBCT were engaged in care. 55% had CD4 testing, 53% initiated ART, 49% were retained on ART, and 53% were retained on ART overall. So comparing that last figure, 86% versus 53%, you can see we have quite a large difference depending on which denominator we're using. So the findings presented here from one population show that facility-based estimates overestimate engagement in the HIV care continuum. Primarily, this is due to the fact that facility-based estimates do not include those who were identified as HIV positive and did not link to care following diagnosis, which this study shows as a sizable proportion. The limitations of this study include potential errors in the merging of data and potential misclassification of non-engagement due to deaths, migration, and transfers that were not captured here. Despite these limitations, these findings imply that the effectiveness of TASP requires achieving 90-90-90 measured at the population level. There is an urgent need for improved strategies to find, link, treat, and retain in care people living with HIV in order for these goals to be fully realized. And I'd like to just also acknowledge my support. Thank you so much.
Very nice. That was great. Thank you very much. Really interesting. Now we have Sunil Solomon.
Good afternoon, everybody. On behalf of all my co-authors, I would like to thank the organizers for giving me an opportunity to share some of our data with you. We are at a stage of the HIV epidemic where what we're really focusing on is monitoring the effectiveness of all our programs. And what was clear in the morning session was it's not enough in the general population, but effectiveness of all our programs, especially among hard-to-reach populations like MSM and drug users in resource-limited settings, needs to be monitored. We all know HIV incidence is probably the optimal measure, but we also know that HIV incidence assessment longitudinally is really cumbersome. There are many novel cross-sectional assays available for estimation of HIV incidence, but implementation of these protocols in several resource-limited settings may not be feasible. The objective of our study was to evaluate biological and self-reported measures that could be used as surrogates for HIV incidence using population-based samples from MSM and injection drug users from India. Our first biological measure we used was the community viral load. So we actually had 3 different variations of the community viral load. So this is an actual recruitment tree of drug users from Manipur. And so our first measure was CVL aware, which is the average log 10 HIV RNA among HIV-infected people who are aware of their status. This is probably the most commonly used measure of people who are engaged in care. So on this figure, that will represent all the orange objects. The next measure was the CVL pause, which was the average log 10 HIV RNA among all HIV-infected people, irrespective of whether they were aware of their status or not. And in this figure will be all the orange and the maroon objects. So what these 2 measures do not account for is the prevalence of HIV in the community. So the third measure we used was CVL-PV, which stands for prevalence of viremia, which is basically looking at the number of individuals in the community that had an HIV RNA greater than 1,000 copies per mil. The next biological measure we used was HIV prevalence, which is very commonly measured, and we used 3 self-reported measures. One was PROP-ART, which is a proportion of HIV-infected people who self-reported that they were taking antiretroviral therapy. The next was the PROP-ACT, which is a proportion of individuals in the community who had access to HIV counseling and testing in the prior year. And our last was COM-SIR, which was a cumulative measure of access to prevention and treatment services among individuals in the community, which accounted for proportion who were on ART among positives and access to HCT among negatives. So we recruited approximately 1,000 participants per site in 26 different cities, but there were 27 sites. We had both an MSM and an IDU site in New Delhi. And so we estimated HIV incidence using a multi-assay algorithm that has been validated for use with subtype C, which is the most common subtype in India. We associated the correlation between our various surrogates and HIV incidence using the Spearman correlation coefficients. We also did a linear regression analysis to examine the association between these different surrogates and HIV incidence. So in terms of the demographics, most of these individuals were like in the mid to late 20s. Most of them were male, low education, low income, but extremely high risk behaviors, as you can see from these slides. So this is what the distribution of the 7 different surrogates we used for looked like across these different, the MSM strata, the PWID sites, as well as overall. Like I know this is a busy slide, but what I want you to observe here is the large variability across the 27 sites, which tracks with the variability of HIV incidence that we saw across the country. The size of these circles represents the size of the HIV incidence. And as you can see in the MSM sites, it's ranged between 0 and 2%, whereas in the injection drug user sites, it ranged between 0 and 12%. So this is an annualized incidence. So now looking at the actual results, so we looked at the correlation of these 7 measures. So that would be the first column. And if you can see, the strongest measure here is your CVL-PV, which is 0.81. So closer it is to 1, the more perfect it is of a correlation with HIV incidence. So this was followed by just straight up HIV prevalence, which was 0.63, which was followed by PROP-ART, which was just a self-reported measure of ART, which was minus 0.54. But what was interesting was neither of the HIV prevention services really had any strong correlation. They were not significant with HIV incidence. So moving on to the regression analysis. So what this coefficient essentially explains is the change in incidence per standard deviation increase in any of your 7 explanatory variables. So if you wanted to break it down into like simpler terms, what it would mean is in New Delhi, reducing the prevalence of viremic individuals in the community from 15% to 11% would result in a corresponding decrease in HIV incidence in the community from 3% to 2%. So this slide is actually comparing those different correlation coefficients I showed you on the previous slide against each other. So this is checking whether one of those correlation coefficients is better than the other. And if you can see in the middle, along the CVL-PV, it is clearly superior to all the other correlation coefficients in terms of how well it is correlated with HIV incidence. And when you compare any of the other coefficients against each other, there really was no statistically significant difference. So what does this really mean? Markers of HIV treatment generally are much more strongly correlated with HIV incidence than markers of HIV prevention services. Prevalence of viremia in the community. We used 1,000 copies per ml as the cutoff, but we also did a sensitivity analysis using greater than 150 copies. There was no difference. And 1,000 copies per ml can be easily assessed using dry blood spots, where you can extract the RNA and measure it. So this is probably an ideal marker where you can't do HIV incidence because it requires avidity index, BD testing, CD4s, which need to be done in real time. This may also be a very relevant outcome for implementation science or community randomized trials, because showing changes in HIV incidence is much harder. But you might be able to show a change in the level of viremia in the community. And in settings where viral load testing and sample collection is not possible, just having a simple self-report measure of the proportion of HIV-positive people on antiretroviral therapy may be a good marker. I'd like to thank my funding sources, the National AIDS Control Organization, our site staff, and all our study participants. Thank you.
Great. Really nice. So now we have Art Poon presenting. Yeah, that's great. If you clean your neck, you can see there.
First, I want to thank the organizers for this opportunity to present to this summit. And I'm waiting on slides.
There's a button there, a green. Not happening?
Oh, there we go. Okay. Yep. Okay. So I'm going to be talking about the implementation of a phylogenetic monitoring system of HIV transmission outbreaks in our province. And this system is built on, the core concept of it is phylogenetic clustering. This is a popular method for characterizing transmission networks in an epidemic. And it works because the time scale of evolution and transmission in HIV are similar. So you can see a lot of evolution occurring within the period of time that the infection is going to be transmitted to the next individual. That means that when we see two infections that are genetically similar, that implies that they're related by one or more recent transmission events. So when we see clusters of genetically similar infections in the population, that can tell us that that's a subgroup of the population where there's an elevated rate of transmission. There's a transmission outbreak that can be identified by this signature. So the BC Centre for Excellence in HIV/AIDS is responsible for all routine HIV drug resistance genotyping in the province. Genotyping is automatically performed on all new patients' baseline samples submitted for viral load testing. And as a result, we've accumulated roughly 30,000 resistance genotype sequences. These data are already available from about 75% of 11,000 people who have ever enrolled in the drug treatment program at the BC CFE. And these all de-identified sequences are deposited in a centralized database at the Center for Excellence with anonymous clinical, demographic, and risk factor data. So it's quite a rich database. So I've developed a system, an automated system that queries this database every hour. So whenever new sequences are uploaded by the molecular laboratory program, those are detected within the hour. If they're present, it performs a phylogenetic analysis of the entire database and then maps clusters on this phylogeny. This determines if new cases in the database appear within phylogenetic clusters, and then those clusters can the clusters are defined as comprising 5 or more individuals. And then it automatically generates monthly and quarterly reports that characterize the growth trend of each cluster and their characteristics with respect to clinical demographic factors. These reports are issued to the center directors as well as the BC Centre for Disease Control and the Provincial Ministry of Health. So I'm going to take some time on this slide. This is one of the largest cluster in the province, mostly comprising of injection drug users. Each point represents an individual. There's a line drawn between points if those infections are genetically similar to some threshold that we've determined. The size of each point is proportional to that person's most recent viral load. So the larger points are the ones that we are paying the most attention to. The small gray dots are individuals who are deceased, and also other small dots indicate that those are individuals with suppressed viral loads. So this gives us a very quick summary of the structure of this part of the epidemic for roughly 250 individuals in this cluster. The new cases in the report are flagged by a double outline around the circle. So that tells individuals who are looking over this report what's happening in the cluster in near real time, roughly about the week or month of that epidemic. We also generate these trend points in time. There's a growth trend plot that shows the growth of that cluster over time, where we've mapped that growth based on the estimated dates of seroconversion. The blue line indicates the total size of the cluster over time. The green line is the trend when we've subtracted out deceased individuals, and there's a big red dot that indicates the number of individuals in the cluster with a detectable viral load, and that's the number that we're most concerned about epidemiologically. So I was quite proud of developing the system and brought this to our collaborators at the BC CDC and Ministry of Health, and they weren't as impressed. So that actually triggered a long process of sitting down and talking with them and saying, well, what would be the most useful information to visualize in these reports? And that was actually the large part of this learning process. What really broke through, though, in this implementation was something that happened roughly in June of this year, where the system detected a cluster that had grown by 9 new cases in the space of about 3 months. And that cluster is depicted in this graph over to the right. Again, each point represents an individual. The ones that are colored red are carrying transmitted drug resistance. Size is scaled with their most recent viral load. And the new cases are highlighted with those circles. All but one of these new cases carried transmitted drug resistance. This prompted a formal outbreak investigation once we communicated these findings to the BC CDC and the Ministry of Health. This investigation is currently ongoing. One thing that we did find is that since this, the majority of the viral loads among the new cases have changed from being high to being undetectable. So in conclusion, it can be difficult to obtain timely information on recent changes in an epidemic. HIV epidemics are complex and in highly heterogeneous populations, often hidden populations. Real-time monitoring of population-wide resistance data that we've already collected, can inform targeted HIV prevention efforts. This also helps in preserving treatment options by detecting and averting transmission of HIV drug resistance in a fine-grained, focused way. And last point is that this knowledge translation from phylogenetics to public health was driven by a recent local outbreak of transmitted drug resistance. Thanks very much. I want to recognize my funding sources, CIHR, NIDA, and Genome Canada. Thank you.
Well, thanks a lot. That was actually fantastic. When they asked me to volunteer to moderate, I had no idea I would see such good science. I mean, it's just amazing. We have time. We have 5 minutes, so I think there's time for questions. So, say a question there from Kevin, and just introduce yourself and ask the question, and direct it to the panel if you could.
Becky and Beth's presentation, I didn't see any. There's an opportunity here for subgroup analysis and some kind of really drilling down, trying to understand a little bit about what's going on, which will help, I think, all of us understand how to improve things. Were you able to, are you planning any sub-analysis, particularly on gender or age or some other subgroup analysis that would allow us to sort of understand a little bit more what's going on? And I guess also maybe to Ruben's point about like sort of sharing data, is that kind of data generally available in terms of the number of women on treatment and the ages of them, and is that sort of stuff that's available for people to do analysis in this area?
Thanks for the question. We are most certainly planning subgroup analysis. This presentation was meant to give a very broad overview of the HIV care continuum as it's represented in this one catchment, in this one sub-county within AMPATH's catchment areas. Yes, we're going to do some more work and look into trying to explain some of the different numbers that we presented today.
Right.
As far as the data sharing question goes, that is something I'm not sure of. I don't know if, Beth, you know if you have any information.
The right answer is as soon as possible, right?
Yeah. We'll get back to you.
But not to interrupt, but I think it's a question we should all be asking ourselves. If we're collecting data on people, we should think as soon as possible about getting it into the public domain. But anyway.
Great. Thank you.
Kevin? Other takers? I see a hand just in the distant background there.
Thanks very much. It's Richard Gilson from UCL here in London. I was interested by your phylogenetic study, and if I understood your presentation correctly, nobody got excited until you had 9 cases in 3 months, and I wondered whether you might lower the threshold a bit, because 9 cases in 3 months linked sounds like quite a lot, and maybe you could do something with this information that you're getting in almost real time a bit sooner than that.
Oh, there's no on button. Okay, thanks very much. I think that one of the major changes that I found was necessary was that I had to expand the time window of these reports. So because of the near real-time nature, if you showed everything day to day, well, you'd see cases popping up every now and then, but tracking what was happening in a 3-month period and a 6-month period, like what allowed us to see those dynamics emerging over that period of time. So that was really what drove that.
So I think it's almost the end of the session. As a moderator, I have one more question. I wanted to ask Sunil from India. Could you just comment a little bit about how your work's influencing NACO, and are they going, without getting you in trouble so you can't return back to your country? Can you just tell us a little bit about how India, how India's seeing your work?
I'm not sure if this mic is working, but
It is.
okay. So we're actually doing a cluster randomized trial of integrated care for MSM and injection drug users in 27 cities across the country. So we're actually partnering with NACO, which is the National AIDS Control Organization. It's a cluster randomized trial. And so NACO has told us for the duration of the study, they will support us, give us whatever resources we need. And if the program is successful, they have promised to replicate our model in other places if we can show it's effective and it's cost effective. So we have cost effectiveness data we're collecting. And because we're partnering with NACO and using existing resources in the implementation of this trial, the sustainability of the research, even beyond the end of the program, is a lot better. So we're just hoping that it works and that NACO will actually stick to their word, because they say a lot of things, but I'm sure you all know in India the government keeps changing every other time. And it's just, we have a new minister. NACO has been absorbed into the Department of Health Ministry, so no one really knows what's going on in India. It's taking us some time to figure it out as well.
Great.
Thank you.
That's
I want to
great.
thank
Great
our
answer.
excellent presenters, a moderator, and we're going to move on to our next session.